Alrighty. Well, hello everybody, and welcome to StandSAFE 2023. And thank you all so much for joining us tonight. My name is Chris Zaro. I'm a third-year medical student at the University of Massachusetts. I'm also one of our local SAFE chapter leaders, and nationally, I help out with SAFE chapter development, along with one of our co-hosts, Jasman. I got involved with gun violence prevention early on in my interest in medicine. My first ever shadowing experience was with a rural pediatrician in southern Vermont. And I didn't know any better, so I thought it was normal that she asked every patient if there was a gun in the home and if they kept the bullets separate and they knew what to do. And by the time I got to medical school, all those years later, having shadowed numerous other clinicians, I had seldom heard that question asked again. I kind of felt like something was wrong, and I'm interested in working with kids, and I'm greatly interested in injury prevention. So taking a role with a wonderful organization that works to prevent firearm violence locally and nationally made it a natural fit for me. I'll now turn it over to my colleague Jasman, let her introduce herself.
Hi, I'm Jasman Kaur. I'm a fourth-year medical student at Michigan State University, College of Human Medicine. I just submitted my residency application today, so we are in great spirits. And I'm applying emergency medicine. And so I got involved in SAFE mostly because it's affected so many identities of who I am, or so many aspects of my identity. I was born in Queens, New York, experienced 9/11. My dad wears a turban, so we often, my community, we were called terrorists, and the first sick man was murdered by a gunman, and then again a Sikh temple shooting happened in Wisconsin. And then my Alpha Phi sorority chapter, my counterpart at UC Santa Barbara, had a gunman show up at their front door. And recently at Michigan State University in East Lansing this past February. So I was just kind of at my wits' end and wanted to do something about it. Started a chapter at Michigan State and worked with my curriculum leaders to incorporate firearm education into our curriculum. So I'm very happy about that. So enough about that. I just wanted to thank everyone who has helped set up this amazing event. Scrubs Addressing the Firearm Epidemic, which goes by its acronym SAFE, is a nonprofit organization of U.S. medical students, physicians, nurses, and healthcare professionals dedicated to eliminating the American firearm violence epidemic through research, education, and evidence-based policy. As we begin, please edit your name in the Zoom so it has your state's abbreviation before or after your name, so that way we can see where we're all coming from. Also, please put yourself on mute at all times so we can eliminate background noise and show respect to our speakers. Thank you so much.
We recognize the need to frame firearm violence as a public health crisis, one which is both preventable and urgent. Today, SAFE aims to advance research in gun violence prevention, to educate healthcare providers and medical students about the latest in gun violence prevention, when and how to discuss firearms with patients, and to support evidence-based policies to reduce firearm injury and death. The primary way we do this is through a curriculum we've built that is a robust tool that we are able to distribute to medical schools around the country. You can find that on our website's homepage. The website is www.standsafe.org. Scroll down a bit and you'll see the clinicians and firearms. Just click that and you're there.
As an organization, SAFE has advocated for federal funding for gun violence research, along with Representative Jackie Speier and Representative Gabby Giffords. We've also worked with California Assemblyman Mark Berman to develop an education and training program on the prevention of firearm-related injury and death. Earlier this year, we sponsored the Giffords Foundation movie and had a national showing of Gabby Giffords Won't Back Down at our National Gun Violence Prevention Awareness event. SAFE has 2 annual awareness events each year to unite chapters and surrounding communities in the shared goals of advocacy to make an impact in this terrible epidemic.
We participated in national meetings and events across the country. We provided one city with data on the impact of gun stores on community violence, and that city then elected not to allow a new gun store to open. 2 of our national board members are affiliated with the San Jose Gun Violence Safety Foundation. We've worked on local levels with gun lock distributions and gun buyback campaigns, and we get to learn from all of you throughout the year as we work to connect with our nearly 60 chapters during the year.
Today, we have the true privilege of learning about and engaging in a discussion on interventions that work to prevent gun violence. Our amazing speaker is Dr. Cornelia Griggs. Dr. Griggs is a pediatric surgeon, critical care specialist, and assistant professor in surgery at the Massachusetts General Hospital, Harvard Medical School. She is the education director for the Mass Gen Center of Gun Violence. Our main session will run for 1 hour with an optional additional 30 minutes at the end of our chapter leaders, or for anyone who is the only representative from their medical school or hospital, which means you're likely one step closer to becoming the next chapter leader. Chapter leaders from Dartmouth are also with us this evening, and they're going to share a bit about what they've done at their campus beginning at around 9 p.m. Eastern Time. Thank you to Charlie McGuire and Ken Greco for joining us.
First, we'll hear from Dr. Griggs, who is also a newly elected board member at SAFE, along with myself and Dr. Sandra McKay of Texas. Dr. Griggs will talk for a bit about her work and what led her to create the avatar she uses to train healthcare professionals, followed by a 15-minute Q&A. Attendees feel free to type questions into the Q&A box at the bottom of your screen. But for now, please, Dr. Griggs, thank you so much for joining us, and we would love to hear your presentation.
Christopher and Jasmine, thank you so much for that lovely introduction. I'm so excited to be here tonight and so excited to see so many engaged students. When I was in medical school, there were no firearm safety prevention organizations on campus. It was not a common topic of discussion in healthcare setting or even necessarily in the health policy world. There were only a handful of researchers who were really even looking at the epidemiology of gun violence. So as a firearm injury prevention researcher, it's really exciting for me to see so many young people engaged and activated on this issue. Because it's my firm belief that you guys are going to change culture and change the paradigm. And that's the only way we're going to see a difference in this horrible epidemic in this country. So I also just want to start my talk, as I start every talk about gun violence, that this can be a really personal issue, and everyone brings a different set of emotions to the table when talking about firearm violence. I appreciate that a lot of people in this room have been personally affected, either themselves or family members. My talk today is mostly about educational interventions and screening in the healthcare setting. But that being said, any talk about firearms is heavy, and don't be surprised if it surfaces unexpected emotions. If you need to take a minute or log off, please do so, whatever you need to do to take care of yourself. And I will also make my contact information available afterwards if there's anything that you want to personally discuss with me. I have a little bit fewer than 20 slides prepared that I'm going to go through. I have a little bit of a written statement prepared at the beginning, but mostly I hope this talk can be conversational. I'm really interested to hear feedback from those of you in the audience, because this is all very much still work in progress and active research that we're doing here at MGH and in collaboration with our partners at Cincinnati Children's Hospital. And I'm really excited to share it with you. So I'm going to hit share screen and make sure my slides show. Can someone give me a thumbs up so I know they're looking good? Okay, I'm going to go to the beginning of my presentation. So again, for any of you who are just hopping on, my name is Cornelia Griggs. I'm a pediatric surgeon at MGH and the education director at the MGH Center for Gun Violence Prevention. I first got involved in gun violence prevention work and advocacy as a resident, and it started with a narrative piece that I wrote with my now clinical partner, Dr. Peter Masiakos, who's the co-director of our center. We wrote a perspective piece in the New England Journal. And that is what kind of launched my academic interest in firearm prevention research. In 2019, so the year after I graduated from residency, the MGH Center for Gun Violence Prevention was launched with a mission focusing on clinical care, education, research, and community engagement. And as both counselors and first responders, clinicians carry responsibility to work to prevent it. Nowhere is this more critical, nor its effect more immediate than at the bedside, where at times it may be appropriate for clinicians and trainees to do three things: to ask our patients about access to firearms, to counsel patients, parents, and families about safe use of those firearms, and if lack of training has been identified as a significant barrier to conversations about gun access and safety in the clinical setting. Even among postgraduate medical training programs with an emphasis on preventative medicine, the vast majority, a little bit over 75% of programs, provided no formal training related to firearm injury prevention. I'm going to show some graphs. So this is data that was taken from a massive chart review that we did at MGH. We did an analysis of our healthcare's own health records using natural language processing, and it demonstrated that among over 80,000 consecutive hospitalizations, alcohol was mentioned in about 69% of encounters. Tobacco was mentioned in about 50%. However, any discussion of firearms was identified in just 425 encounters, or about 0.5%. Furthermore, in a retrospective review of pediatric patients who presented to our hospital's emergency department with active suicidal or homicidal ideation and who were seen by pediatrics residents over a 12-month period, only 5% were asked specifically about access to firearms by the treating emergency department resident. In a quarter of these cases, no discussion about firearm access was documented in the medical record by any clinician before the patient was discharged. So what we learned from this data is even in some of the most high-risk settings, this topic, this conversation comes up rarely, if at all. So this is a slide that just kind of covers the 5 L's, which may be something that you guys are familiar with and have heard of before. It comes from Garen Wintermute's work out of San Diego, but I always like to include this as a learning slide because I don't like to assume anything of anyone who comes to these talks. And maybe you've never been trained to bring up access to firearms at all in a clinical setting, but this is a really great and easy way to start. I like to give the example prompt. Because there are risks to having a gun in the home, I ask all my patients about firearm access and safe storage, kind of like Chris was mentioning what he experienced in the primary care setting in Vermont. This is the way a lot of providers will sort of bring it up in a casual setting, in a clinical encounter, whether you're seeing someone for an OB visit, a well child visit for peds, or whether you're seeing someone in the emergency department. It's a really easy way to just integrate it into your social history. And you start with the question, do you have any guns or firearms in your home? If the answer is yes, then we ask people to counsel on the 5 L's. Is the gun locked? Is it loaded? Are there little children present? Is anyone at home feeling low? And is everyone at home learned about the principles of safe firearm storage? So those are some of the basics of what you can start doing at the bedside. But when we realized how little people were bringing up firearms in the clinical setting, we developed a novel standardized patient-based curriculum. And this is a curriculum where our residents are given case-based scenarios to match their specialty, whether that's internal medicine, psychiatry, emergency medicine, OB, surgery, etc. We kind of have customized, tailored case-based scenarios for each of those specialties. And we allow our residents, usually when they're doing their intern year onboarding, kind of like the boot camp at the beginning of the year, or for some of our residencies, we sprinkle it throughout their didactic curriculum during the year. But since 2019, we've trained probably close to 1,000 residents at this point across departments through our novel case-based simulation program. And those graphs there just sort of show the change that we saw in familiarity with just basic topics, whether it was the 5 L's, whether it was bringing up a red flag law, learning what a red flag law was, or an ERPO, or how to file one, or who can and cannot file one, as that varies from state to state. But our residents are training in the state of Massachusetts, so our curriculum in Massachusetts is tailored around Massachusetts gun laws. This is a nice graph that just shows the improvement. We did some chart biopsies before and after we trained these interns, and we saw that there was a significant increase in documentation of screening and counseling among those who had been trained. We have made our curriculum freely and widely available. It's published here in Academic Medicine. If you want to screenshot this and you have the capability to take our curriculum and run with it, we want as many people to do it as possible. But because we train our residents using standardized patient actors, we recognized pretty early on that there was a lot of hunger and interest in scaling this kind of curriculum at other institutions and nationwide. And we have done that. We've done it during COVID. We did it over Zoom. We trained our standardized patient actors to deliver the curriculum over Zoom. But we realized that component of requiring standardized patient actors was definitely a rate limiting step to scaling our curriculum. And so we decided to partner with Matt Zakoff and Joe Real, who are amazing peds critical care physicians at Cincinnati Children's Hospital. And they have an innovation lab where they had built an avatar-based platform to train residents how to do vaccine counseling with parents and families. And we decided to build our gun violence prevention curriculum into that avatar platform. So this is a screenshot that shows just sort of, you can see the technology kind of looks like probably a low-level video game. And you guys today in medical school probably are so much more comfortable and accustomed to doing a lot more of your curriculum virtually or through sort of like simulated scenarios online. A good example of this nationally is ACLS Heart Code, where you actually, if you are getting ACLS trained, you can kind of click through avatar-based scenarios to get certified in ACLS. But we don't have quite that much funding, so you can see the fidelity of our technology is sort of at a beginner video game level, but we have grand ambitions for this to be fully AI driven down the road. But right now, there's still kind of a Wizard of Oz behind the scenes. So our trainees interact with the avatar, and then the Wizard of Oz behind the scenes kind of chooses how the avatar will respond. And we have built several different versions of avatars, different races, gender identities, and we've tried to make it so that the scenarios are applicable across multiple specialties and disciplines. So let me make sure, this is always the part where I have to make sure I've shared sound, because I'm gonna, hold on one second, it's asking me to log in again. Sorry, this part always causes technical. Okay, just give me a thumbs up if you hear the sound.
Do you have any information on how to store the gun safely?
I think the cable lock could work. Where do you get a cable lock?
I will check with family who watch Alex to see if they have any guns in their homes.
We will look into getting something to keep the gun safe this weekend.
So that's kind of a video clip that gives you an example of the different avatars, some of the different responses, but we worked really hard to try and make the scenarios very realistic. And we did a lot of focus groups with our residents and trainees. We worked really closely with our standardized patient actors because we've been doing this curriculum now for a few years, and our standardized patient actors are so good at the curriculum that they are actually now sometimes functioning in the role of educator, actually like correcting our residents in real time as they're going through the training. And we had a lot of concerns about maintaining the fidelity of our curriculum as we transitioned into something that would be more easily scalable. which is why we're really excited about the avatars, but we also recognize that it's imperfect, right? That there's like some awkwardness interacting with an avatar that might not match the integrity of a person-to-person encounter, but it's pretty close. It's pretty good given what we had in the startup funding that we had to kind of build this platform and curriculum. So now I'm just going to share some qualitative feedback from participant interviews, and I'm excited to share that we're just about to submit our manuscript about on the feasibility of this avatar-based curriculum. And so far, the feedback from our trainees is really good. So just in terms of overall impressions, and this is mostly from third-year pediatrics residents. So a lot of them were actually somewhat familiar with a rudimentary firearm injury prevention curriculum. Many of them had done the AAP website curriculum. So a lot of these trainees are not totally unfamiliar with the topic, but I kind of highlighted some quotes that I'll share. One resident said, "I don't have a lot of experience with firearms, so definitely learning about safety storage devices was something new for me. Really helpful as someone who knows nothing about guns and only knew about gun safes. I don't have good counseling on what to do about it, so I think that was really helpful. It was really digestible, highly relevant, highly applicable to routine encounters that we do all the time, and potentially extremely impactful. The real advantage of this interface has for us as pediatricians in practice is because it is hard to practice in real life." And that's something that we heard over and over again, that the benefit of being able to practice in a safe setting. And in the avatar-based curriculum, what we did is we had trainees run through the scenario once and then get direct feedback after they did the scenario and then do it again. And what we heard over and over again from trainees is having the opportunity to practice in a safe space, to get direct feedback, made them feel so much more confident, and just they felt really knowledgeable deploying these skills in the clinical setting. And we think that's really where the magic is in the sauce. And that is consistent with what we know from the adult education literature, that having the opportunity to do a simulation in a safe setting, to get direct feedback from an instructor, and in some cases your peers, is really what's going to move people from the passive learning state to the active learning state and feeling comfortable and confident deploying these skills in clinical practice at the bedside. So in terms of what our learners like the most, they like the topic and the choice of educational methodology. They like the inclusion of pre-simulation teaching. There's also a didactic component to the curriculum. It's about 25 to 30 minutes where we sort of go over the basics of safe firearm storage. If you live in a state where there are URBOSA red flag laws, what that means, who files them, why it's important for clinicians to know about them, and specifically practicing ways to talk with families about household firearms, especially for those trainees who are not familiar with the topic at all or have had no prior safe storage counseling. And then again, the opportunity to practice, then receive timely feedback and specific education on their questions. Things that learners like the least, generally there were very few participants reported any things they didn't like. One participant experienced a lag in what they saw versus what they heard in real time, which felt awkward. A few felt that inevitably you're going to meet families who are very resistant to change. So maybe having a scenario to practice how to respond in those situations would be helpful. Mostly what we heard is that they'd like more scenarios and more variation among them, which is something we can easily accommodate. 100% of the people who were in our pilot feasibility study said that they would recommend this curriculum. And we were really encouraged by that positive feedback. So again, there are multiple curricula out there, but what we think is really valuable and different about ours is the ability to practice in real time and then get direct feedback. Obviously, we're also really big fans of clinicians and firearms. In the absence of having this training everywhere, it's incredibly crucial and important that we have free available curricula that people can start with online when they're looking for something to educate themselves and to start with and to deploy tools rapidly at the bedside. We also think the AAP safer curriculum is good. And one of our fellows will be presenting at the National Firearm Injury Research Conference in Chicago in November about comparing REACH to residents who just did SAFER to residents who did SAFER and REACH. So I don't want to scoop her with her data, but it's encouraging. So in terms of the next step of our work, we are looking, again, to scale as quickly as possible. We are in conversations with multiple different educational platforms to sort of put this curriculum, to make it fully AI generated, which would take a big dose of funding, but also to have this exist on an easily accessible online platform, because our goal is to make this freely and easily accessible to all clinical trainees and clinicians who want to implement firearm safety screening and gun violence prevention into their clinical practice at the bedside. And so we're in talks with multiple partners and foundations, and we are also really interested in deploying and directions. If there are any of you out there who are interested in this, we absolutely are thinking about training medical students. Some of the other work we'll be presenting at the conference in Chicago is our work modifying this curriculum and training school nurses to do this kind of screening and counseling and prevention in schools, because we all know the conversation of gun violence in schools is one of utmost importance and a real pressing crisis in this country. So we want to train more healthcare providers in different fields, in all specialties. And if you're interested, we'd love to think about ways to engage with you. And I'd love to open this up to questions.
Thank you so much, Dr. Griggs. That was truly incredible. And there's so much to think about from a medical education standpoint to a firearm perspective. Anyway, I hope we can get a lot of questions going on it. Jasman put something in the chat saying that they did some simulation-based training about firearm injury prevention through SAFE at Michigan State.
Nice.
And they're presenting a poster on it at a National Firearm Research Conference in November.
See you there.
Yeah, oh, great. Yeah, but she said she'd love to talk. Chat. I mean, it's your talk. It's something that we've thought about a lot with SAFE, but do you think that this curriculum is particularly built or specifically built for residents, or do you think it could work well in a medical student setting? I mean, you talked about it working with school nurses, but do you feel like it has, maybe my question is specifically, why did you choose to start with residents, and do you see this as being applicable to everybody?
Yeah, we started with residents because this type of module and education very much aligns with some of their didactic curriculum as well. They are also a study population that we have easy and ready access to as hospital-based clinicians. It was the right mix of novelty, but enough experience to be able to engage. One of the tough things about doing the curriculum, the first time we did it with school nurses, is we actually had nurses who had never worked with a standardized patient actor. And so part of the struggle of getting through the curriculum was just sort of getting over the hump of kind of practicing. And some of the nurses felt really shy because they felt like, am I in acting class right now? Like, you can imagine if you've never worked with an SP, that would be a barrier. And we didn't even, that was our very first one with nurses, and we didn't even think about that. So then the second time we did it, this is science happening in real time, like trial and error. So the second time we did it, we actually just spent kind of 2 minutes explaining what is a standardized patient actor. And we sort of we did a little preview of what it's like to do before we had people go into breakout groups. And so we know almost all of the residents that we've worked with at some point have worked with the standardized patient actors. And a lot of medical students have too, but you can imagine there would be first and second years who maybe haven't, if they haven't really done any OSCEs. So that is one of the reasons. But yes, absolutely. I think medical students are a study population and a group that we are very interested in engaging and targeting. I think you guys are actually probably poised to give us some of the best feedback on this, because so much of your education has happened online at this point, right? And so we really need your feedback and engagement as we work to scale this research.
As a third year, I can say I'm certainly getting to know the standardized patients tricks.
Yes. It's a big part of your life now.
Yeah, and it can be intimidating. That makes sense. Jessica was asked, put in the chat, how did you teach firearm safety?
So as I mentioned, there's a 20 to 30 minute didactic curriculum. If you're interested in looking at it, it's published. Again, I'll show you in the journal Academic Medicine. I'll share again. Hold on, I'm just toggling between screens because I'm on a laptop. Oh. Hold on. It is published there in that article. If you, for some reason, can't access that article, we are also happy to share our didactic slides. And just with the caveat that depending on what state you're in, some of the didactic curriculum may or may not be relevant.
I don't know if I'm on or not. I guess not. Heck.
I hear you talking.
Oh, okay. Am I
Yeah.
still there? Oh, all right. No, I have this. I mean, I'm going to get access to that. I appreciate it. What I'm talking about is when you have your medical personnel. I'm not a medical person. I'm a retired cop. You know, when I teach firearm safety, it's hands-on with firearms. And
Yes.
I don't know if any of your people have, is there any thought to presenting something like that to your students or to the staff or anybody like that to explain a little more to the people you're talking to?
Yes, absolutely. I think there is absolutely a role for that. And we have worked with the Boston Police Department on that very topic. There is not a lot of specific safe firearm handling education in the curriculum. It focuses more on storage and access. But I absolutely think there is a role for that.
Yeah. Okay. Storage is important. Julie Parsonet and I are out here in San Jose trying to sort out San Jose's gun farm ordinance. And, you know, the city's still kind of, what am I going to say, waddling in the mud. But what we're trying to do, or at least what I'm trying to do, is put together a program for citizens relative to red flag laws, which are very important, safe storage, which is very important, but also dealing with people in the medical area. And I don't know if any folks on this program are from San Jose or not. You know, I'd like to get up with them or talk with them. So I don't know, whatever I can do to help. But
Wonderful. Here, I'll also share this slide. This is part of our, I skipped over it, but this is like an example of one of the slides from our didactic portion about safe storage and putting the cost next to each.
yeah,
storage.
that's great. That's good.
Yeah. And we've got handouts and stuff like that.
Yeah. Okay.
So Jess, this is Julie Parsonet here. And just to say that we actually do teach a course called Physicians and Firearms at Stanford, and we have taken the students to a firing range to learn how to handle guns and to give them education on how they handle weapons and what the parts of a weapon are and how to put the, you know, how they types of different ammunition. And the Clinicians and Firearms does talk a lot about weapons themselves, but I don't know, Dean, if you want to comment on I think it's very valuable to teach doctors about firearms themselves.
Absolutely. Again, they get a chance to, fire different revolvers, including 45s, semi-automatic pistols, both 9mm and 40 cal, and then AR-15. And I just want you to know, as a military veteran, I did show them up, and still can ace the shooting.
How come I was never invited? You scared to have me shoot against you?
Yeah. I'm sure.
Next time we teach it, we'll have you come.
Thank you.
Yeah.
And actually,
Yeah.
let me just say that one of the obstacles to it is it's very expensive. We took them to a firing range and it was very expensive. And we'd love to figure out how to work with the police departments to actually learn that way, because going to the firing range was
Yeah,
it was
God,
it was
yeah.
a few $100,
Yeah.
and
Holy
and
cow.
yeah.
All right, I'll talk to Sheriff Johnson. I know him pretty well. Maybe we can use the sheriff's office range.
No, I absolutely think there's a role for that. But I also just want to acknowledge that, depending on your clinical setting and depending on your own personal background, like I started the talk, for some people, even the idea of handling a gun is really traumatic. And that doesn't mean that they can't do good counseling at the bedside.
Yeah.
So I think everyone sort of brings a different context to the table. And I want to be, culturally sensitive to the fact that somebody who's lost a family member at the hands of a firearm just may not be comfortable being in a firing range, may not be comfortable hearing the sound of gunshots. So I think we try to keep that in mind when we go through our curriculum to make it as widely applicable and adoptable and scalable as possible. But to your point, I think for some people who are doing this on a really frequent basis, where they're going to have patients who have specific questions about how to handle a weapon or a firearm, or to have better language around which types of weapons may inflict which kinds of injuries, there are definitely people who are hungry for that kind of education in the clinical setting. Okay, I see some questions in the chat. I'm going to do my best to answer some of them. I see Samantha. What have been some of your toughest obstacles you've faced in your research so far? So I'll give an example. It's not only my research, but it's my clinical practice. I think that because the firearm injury research space was so vacant for so long, at least from the setting of academic medicine and, academic healthcare research, as we think of it, like NIH sponsored, we are deploying interventions and educations in real time before we have a huge body of evidence behind them, right? Like you would never prescribe a drug to a patient unless you had multiple randomized controlled trials showing you that that drug worked. And we are asking people to deploy this tool and this education with a lot less evidence than that, right? And we are asking people to kind of be experimental, right? And that can be hard because it will naturally bring up negative consequences that we can't anticipate. I'll give you an example. I do routine screening in my clinic, and I had a 4-year-old come see me with his dad for a routine check for an umbilical hernia. And I was doing my screening, and I asked about guns in the home, and the dad who was in the room, who is a doctor himself and a former veteran, said, well, we do have guns in the home, and now my 4-year-old knows that. And that was sort of the first time I'd realized I'd stumbled into a scenario where, with the best intentions of doing screening, and, this former veteran was better versed than I am on, say, firearm storage in the home. And I had sort of stumbled inadvertently into a scenario where, like, a parent may not want to or be ready to disclose to the 4-year-old that there is a firearm in the home. And some people would argue, well, at age 4, that kid actually probably does know that there's a gun and probably actually knows where the gun is, even if the parents don't think about it. And there's data to show that families who do own firearms, many parents think that the kids don't know or can't get access to the gun. The vast majority of the kids know and can get access to the gun. So that's the counter argument to that. But anytime you do research like this, right? Anytime you're deploying an intervention before you have a huge body of evidence behind you, you're going to stumble into pitfalls like that. And I still think that the value of the curriculum and the value of normalizing this conversation in the context of a healthcare setting, in a clinical setting, ensuring that doctors and all healthcare providers become safe and trusted messengers when it comes to the conversation about gun violence prevention more generally, and specifically firearm safety counseling. I still think that outweighs, the potential downside, but there are only going to be more scenarios like that where I say, I didn't think about that when I thought about the value of deploying this curriculum and universal screening, for example. Okay. We are working on hands-on firearm training out there as well at Dartmouth. Jasman, we created an elective at MSU and have a lecture address anatomy of firearms. Awesome. Love it. From Julie, in your opinion, what is the ideal method to assess the benefits of the curriculum in the longer term? So one of my slides I showed you, we used NLP or natural language processing to look at the change in documentation of screening, but we know that's an imperfect proxy, right? Because there may be people who are doing screening, but not documenting it in their note. So that's a really important question. And especially in terms of like building a body of data and evidence, I think that's probably our best metric, the same way we look at domestic violence screening, the same way we look at screening for depression, alcoholism, tobacco use. It's through the medical record. I think that's probably our best tool in terms of normalizing and contextualizing the conversation about firearm safety in the healthcare setting, recognizing that it's almost less important than the kind of culture change that I'm talking about. The fact that you guys are a generation of medical students who are now going to be engaged in the conversation about firearm safety and gun violence prevention in the clinical setting, right? I really think that is the essence of the importance of this curriculum, is that we are having the conversation. We are normalizing us having the conversation. It goes back to hashtag this is our lane, right? And that's the big piece. But in terms of measuring it and proving its importance, I do think it's going to be in documentation in the clinical medical record, unfortunately. Or fortunately, because it's a straightforward measurement, but you need like kind of advanced NLP tools to do it. But they're out there, they exist. Do you think it would be feasible to get a standardized education implemented in medical school curriculum? We would love that. And if there's any organization to make that happen, this is the organization to do that. We've had sessions with SPs learning to take histories, something. Yes. You are thinking, we are leading you down that road. So thank you for asking that question. And I see Jasman responded to it too. Okay. Allison, can you compare and contrast your curriculum to other bullet points? Does your curriculum deal with temporary transfers in addition to safe in-home storage? So I would say like the curriculum itself is somewhat modifiable, right? And there are now 4 or 5 different versions of the curriculum. There is a Texas version, there's a Massachusetts version, there's a New Jersey version. We've probably done close to 10 different states at this point. And we've modified the curriculum for nurses too. So the curriculum itself is modifiable, like that. What we teach in that didactic portion can be modified based on the needs of the trainees who are coming through. And that's what's nice about the avatars too, is kind of like once you have the environment built, putting the different language and the prompts and the responses in is relatively straightforward, right? That's just scripting. Oh, can you explain very briefly how the avatar interaction works? Yeah, so it's like being on Zoom, and it's kind of like being in a video game is the best way to describe it, I think. Or like you're a little bit clicking through, but you'll interview the avatar, and then the person who's running the program will choose a response for the avatar. And it'll either be positive or negative based on your interviewing skills. How was your curriculum adapt? Did that answer your question, or did it not answer your question?
That was someone else's question that I posted.
Oh, okay. Got it.
I
Got it.
think you did a good job of just, yeah.
Okay. Yeah. I think a video game is the best way to explain it to someone in an older generation. How is your curriculum adapted to address patients' increasing concerns of home defense and personal protection when it comes to safe gun storage? I would say we haven't got that far. I mean, we're working on ensuring that clinicians feel comfortable and confident engaging in this conversation with patients, but that's probably a level that we haven't addressed yet, but is definitely worth addressing if you have ideas.
Can I actually ask a question related to Danny's question about getting sort of this, adding it in with standardized education? And I think it's something that I've struggled more broadly with like firearms research and thinking about firearms in medical education is sometimes I see it added in with other forms of injury prevention and standardized questions, and sometimes I see it as very separate. And it's I come from a bit of a biased perspective, having led this StandSAFE event this year, thinking that firearm education is particularly important given like the severity of the epidemic and how much it feels like it's not being addressed. How do you see, like, with the goal of this sort of educational program, do you see it as trying to normalize asking about firearm safety? It seems difficult to me. Do you kind of get what I'm asking about?
I think it depends on where you are. I think it depends on where you are and what the institutional buy-in and support is, where you are practicing or where you are learning. In Massachusetts at MGH, we are staunch advocates that the Gun Violence Prevention Center is its own thing, right? We have an injury prevention center. We have an injury prevention team, and we love them and we work closely with them. I wrote an op-ed about drowning prevention last year for them, but that is very distinct and separate from the work that I do in the firearms space, which is very specific and dedicated to the gun violence epidemic. And we're pretty staunch about that. Like, we refuse to be folded into other larger injury prevention organizations, and people have tried. So, and it's not a bad thing. However, our partners in Louisiana, in New Orleans, for example, their hospital will only support them and continue to fund them insofar as they are a part of keeping children safe, injury prevention, right? They can only exist under the safety and the umbrella of the larger injury prevention work that the Children's Hospital is doing. If they were their own thing, the hospital would not fund them. So it depends.
Yeah, it's as much as we can treat a firearm like a car seat, I guess. Yeah, that makes sense. Thank you. I think there are a couple more in the chat also.
Okay. Do users have the option to make the scenario harder, such as a patient not receptive? So the person, Wizard of Oz behind the scenes, yes, has the option to make it harder. Yes. But we don't have a patient who's just like completely off the wall, unreceptive, belligerent. That was actually one piece of feedback from the trainees when we did the feasibility trial, is like they actually wanted to practice talking to a patient who just like wasn't having it at all. So we didn't have that built in, but it will be in the next iteration. We had people who were resistant or reluctant to have the conversation, but nobody who was aggressive, I would say. How do you recommend responding to patients who believe that doctors need to stay in their lane? And right. So that goes back to sort of like folding it into injury prevention. My job is to keep you and your family and your body safe and healthy. And we know that gun violence is the #1 killer of children in the United States, right? Like, that's an alarming statistic that gets repeated over and over again. But firearm injury has surpassed motor vehicle collisions as the #1 cause of death for children in the United States. And therefore, this is my lane specifically me as a pediatric provider. That's an easy way that I justify it. But I think it is undeniably a public health crisis in our country, and that's sort of ideological. And I think there are some patients who aren't going to be receptive to that, and that's okay. There are patients who are unreceptive to smoking cessation and who are going to continue to drink alcohol despite our best counseling and efforts. And we just want to make sure that the people who want to deploy this curriculum and these tools at the bedside have the tools to do that, right? Like there are 400 million guns plus in circulation in the United States. I'm not under the illusion that this curriculum alone is going to change the mind of every patient out there, but you can begin to slowly chip away at culture change for sure, or quickly. And it's already changed so much. I mean, seriously, since 2018, when I first started doing this work, there were no government-sponsored grants from the NIH looking at firearm injury research. And now there are multiple R01s with NOCs or notification of special interest specifically in gun violence prevention. So some of that is political climate, some of that is demand from our country's population, some of that is, shifting interests and aligning, that with the values of the NIH. But that's in 5 years, right? The landscape is changing fast. This is an amazing time to become a firearm injury prevention researcher if you want to become one. I love to see all the people who are saying like they're going, that conference isn't even that old. It's a pretty new conference, and to see medical students knowing what it is and going to it is an exciting thing. Okay, what do you think are the barriers to mandating this kind of education? Meaning, why would medical schools and hospitals not? Political landscape, right? And even in Massachusetts, right? Like we have a fundraiser coming up for the Children's Hospital, and the topic this year is adolescent health. And at some of the fundraisers that I went to drum up interest for the hospital, I was sort of like quietly discouraged from mentioning my work in firearm injury research. And sometimes I listen and sometimes I don't. But there is still a lot of fear in terms of alienating funders or alienating people whose political beliefs don't align with the Center for Gun Violence Prevention. And we specifically called ourselves a Center for Gun Violence Prevention, not, firearm injury prevention, which is more palatable and adopted by, some other centers. I would say we're a little bit more on the fringe there, and that's because we have the safety and the protection and the buy-in from our hospital and institution, but it depends on the political landscape where you are learning and where you are practicing. And I would say that is one of the major barriers to academic institutions wholeheartedly adopting this kind of curriculum, is fear that one of their major benefactors is going to say, "What are you doing? I'm pulling my donation. I don't agree." I don't know if that's actually happened anywhere, but there's definitely fear of it from the development side. How do you see even in Massachusetts, how do you see the role of community school outreach and education working most effectively in combating gun violence? How can we best go to our patients before they become our patients? Yeah, I mean, prevention, right? I love to think about, things on the back end, but the goal is to prevent people from getting to the point where they're in such a state of despair and have easy access to a weapon where they become our patient or inflict a wound on somebody else who becomes my patient. And this is a really dicey conversation too, because I don't like to chalk it all up to mental health, but I can tell you from the work that we did with school nurses, we did a lot of focus groups trying to figure out how to get that curriculum right and how to create the most realistic and most meaningful scenarios where school nurses could kind of practice having that conversation with parents and families in a way that felt realistic to their day-to-day life. And what we heard over and over and over again from people working in schools is that the mental health crisis among young people is devastating. They do not have nearly enough resources to provide even low quality mental health care to their students, that the majority of the school nurses we interviewed believed that a gun violence event or an attack of some kind involving a gun at their school was not only probable, but inevitable, and how much that weighs on the mind of people who are showing up to school buildings every day for work and to try to learn how much gun violence weighs on the minds of parents who are putting their kids on the school bus every day, how much it weighs on the minds of kids who are growing up in a generation where doing lockdown drills has become normalized, where they're rehearsing and practicing their own death. And I think it's a really hard time for young people. So I don't want to chalk it all up to mental health, because the other piece is having easy access to a weapon, right? It's access, it's a number of guns in circulation, it is laws and regulation in your state. It's multifactorial, it's income inequality, it's systemic racism, it's injustice on so many levels that is driving the epidemic. And there's nobody out there who's waving a wand getting rid of income inequality, right? And it's all tangled up in each other, and we have to combat it from multiple angles, because the gun violence crisis looks very different in rural Maine than it does in Camden, New Jersey. And so there isn't necessarily a one size fits all solution, but there are some things that we know work. If we federalized Massachusetts gun laws nationally, we could expect something like a 60s. Competing with the educational demands of medical school. That's definitely that in states like Massachusetts and California, that is definitely a major hurdle and a major issue, is making sure it's prioritized and that it gets on the docket. And I think that injury prevention researcher, as a clinician and as somebody who works at an academic medical center. So I completely agree that depending on the political climate where you are, getting it to be a priority when there are a lot of other competing demands matters. Violence, right? It used to be a really taboo topic that was hard to talk about. We didn't feel like we had a lot of good recommendations for interventions, and now it is a standard of care, right? So you can see dramatic change in as little to 10 to 15 years on topics that we previously thought were taboo or hard to talk about or weren't being prioritized.
We probably have time for one or two more questions if folks still have any. Just give it a second for folks to type. Not some hunt and peck, takes a minute. But if not, thank you so much, Dr. Griggs. This was an incredible talk, and I so appreciate you answering all of these questions and starting such a wonderful conversation. Like, really, this is incredible work. And as a medical student, I can say this is very inspiring. As someone who works with SAFE, this is very inspiring. So it's really wonderful to hear all that you're doing.
Right back at you. You guys are the inspiring ones. You guys are the future. And I can't tell you how meaningful it is to know that you're out there. This is an open invitation to work with us in our group. I would love to know more thoughts and feedback. Like I said, this is a work in progress. This is something we're building in real time. And the more input we have from today's learners and future clinicians, the better it's going to be. And again, our goal is to, get this on a platform where it is widely and freely available as fast as possible.
Excellent. Well, as Allison put in the chat, the final 30 minutes is intended for SAFE chapter leaders or for those who are the only folks from their institution. But before folks sign off, I do just have a quick a quick little ask. We'd love for you folks on the call, if you're interested, to consider supporting SAFE with a donation. We're in the midst of a very big and exciting challenge grant where we have a goal to raise $50,000 between now and the end of December. For medical students, I understand that it could be it could be challenging to donate financially when time can already feel like a tough thing to donate. But a donation of $5 a month, if that's available to you, can really help to do a lot of good. So please consider making a donation. There's a donation button in the chat, I believe. And if you're planning to do it, don't be afraid and aid to do it now while you still are sort of have this talk on your mind. And if you have more access to financial resources, maybe you're no longer a medical student, for which I say congratulations, it's very impressive. Maybe you or your family has the means to make more significant impact on the issue. You can use the same link there to make a donation of $4 a month, which goes up to $1,000. Again, that link is in the chat, or it's at our website. We have dollars, so it's a lot at stake for us now until the end of December. So Jasmine, do you want to talk a little bit about the other SAFE news that we've got going on?
Absolutely, Chris. So we do have SAFE scrubs. So if you're from Emory, East Tennessee State, UC Irvine, Michigan State, or UCLA, your scrubs have been ordered and are on their way. If you're from a different medical school on this call and want to order scrubs, use the link in the chat and we will get your chapter some. And one final thing before we get to our Dartmouth leaders, we want to share that our new SAFE chapter resource repository, which you should absolutely click on chapter meeting ideas, links to books, movies, and very helpful gun violence prevention resources that are definitely a must resource that you should have as a chapter leader. All right, Chris, want to take it over?
Yeah, we'll pivot to actually to Charlie and Ken Greco, who are our SAFE chapter leaders at Dartmouth Medical School. You all been doing some very inspiring work, so we'd love to just hear a little bit more about it. Charlie, actually, if you don't mind introducing yourself and your Dartmouth group, we're eager to hear about what y'all have been doing for maybe the next 10, 15 minutes, whatever you have to share, and then some folks can ask questions whenever they're ready.
Yeah, hi. So my name's Charlie, third year med student out here at Dartmouth, along with Ken Greco. Prior to med school, I'd been in fire and EMS for about 10 years. Had worked as an investment banker and was getting my PhD in economics before deciding to transition to medicine. So like most med students, I got my master's in like I said, fire and EMS for 10 years, really on the rural side of Colorado and Ohio. So I've had a lot of exposure to firearms in homes and around businesses, so on and so forth. And I remember one day after first year or second year, I was talking with Ken. I said, Ken, I don't think we've learned jack about firearms here. It's a very uniquely American concern in the medical community. And we haven't been taught a single thing about it, despite the fact that it's a leading cause of injury and death in our country. So Ken and I kind of put our brains together and we thought, well, we could at least get some med ed research out of this, right? And then it turned into a huge passion project. We got engaged with the trauma team here at the Dartmouth Hitchcock Hospital. And we've put on now 2 seminars, 1 panel, and we're trying to kind of consolidate a formal, at least elective, if not integration, into the course curriculum about firearm education. We actually didn't know about SAFE until pretty recently, so it would have been nice to have known about them y'all before, because then a lot of our lead work actually ended up overlapping a lot of what SAFE has out there. So we can really vouch for the SAFE materials. Ken, you want to introduce yourself?
Yeah. This all sounds great. And like Charlie said, we've kind of taken our own approach to this and then realized SAFE was out there. So, but anyway, yeah, my name's Ken Greco. I'm also third year with Charlie. And I think a lot of my interest in this, I mean, I was never a firearm owner or anything like that before med school or anything. Still not, but just hearing things in clinic about how clinicians I was with would group firearms with like political groups or firearm owners with political groups or say things behind closed doors, and just not thinking that adequate screening was done for firearm ownership and safe storage and access to safe storage items. So that kind of got me intrigued with this. And I think it was first year, actually, Charlie, when you started talking about this with me, and we kind of just were like, there's really nothing out there that we can find at our institution regarding firearms. I think we had done a lot of background research and start there. So we ended up with an initial seminar in January of 23. And we really tried to frame firearms and just frame the physician, position in the discussion of firearms is like, how do we approach this in an unbiased manner? How do we change the language we use when discussing firearms? And how do we really just try to meet people where they're at and really avoid that, historical demanding, you will do this, or you will not own a firearm, or you will get rid of your firearms, that kind of language really. We ended up integrating a Stop the Bleed course, which our institution didn't really offer any kind of acute stop the bleed, acute trauma training. We brought in a bunch of speakers that really tried to approach firearms with a patient-centered ideology, and really just tried to emphasize the importance of, like, number one, recognizing that we don't really know much about firearms as, a medical student versus someone who owns a firearm, unless you're a medical student who owns a firearm, which there aren't that many, but they're out there. And just being conscious of that, and figuring out how we can really approach this in a non-judgmental manner, how we can connect people with resources like gun locks, trigger locks, etc. That our school, that our program actually has, but throughout our large Dartmouth system, some, it's offered at this department of the hospital, and the other department isn't aware of it, or the patient safety center has access to them, and medical students are never the wiser of any of that stuff. So really just shoring up a lot of the logistics and starting the conversation on how we can approach this from a medical student and eventual clinician perspective, and really feel like it's in our lane, and that we're not talking down to others or being very speculative and talking about firearms without really having any right to do so. So that was kind of our initial approach. We most recently, and Charlie, maybe you could fill in more on this. Which is a film produced by Jenny Herzog. So that kind of is a film following, I think it's 7 individuals and their stories. They're young individuals, children that grew up around firearms. I believe it's actually set in Massachusetts, and just exploring root causes of firearm violence, gun violence, etc., and hearing their stories. And we thought that was really impactful to kind of screen. And Charlie, if you wanted to fill in on just like our idea for the seminar.
Yeah, so we were connected with Jenny Herzog through a physician at Dartmouth. And so her movie is about Western Mass, about a small town in Western Mass, and the impacts of gun violence and how it's impacted a group of kids, and more importantly, kind of their perspectives on firearms as a consequence of it. It's a very impactful, very thoughtful film. And it's actually, we're going to bring up a few of those kids up to Dartmouth to have them speak to the Dartmouth community about one thing that they kind of said, we'll give you an interview, but we know it's not going to matter. So if anyone is interested, Jenny is actually very eager to kind of spread this film far and wide and have it shown at other institutions. So if you all are interested in having a showing of a film, this is a wonderful film and we recommend it. That we also discussed during the Hear Me seminar was gun violence and homicide as a public health priority. We had a DEA agent in charge. We had a psychologist who had made a few rounds on NBC. And then we also had our trauma surgeons, who gave their perspectives on how firearms impact not just physicians, but how firearms impact the wanted to make this is, a lot of things that we learn about in medical school, especially if you're interested in surgery, you're not really going to do until you're a resident. Even then, sometimes not even until an attending. However, talking to patients about firearms, proper screening questions can save a life from day one as a med student. This is something you can do as a first year that could possibly save a life of a little kid or of someone in distress. Are you going to break through to everybody? No, of course not. But you do have an opportunity here to educate someone. And compassion and sincerity. Luckily, the MD or DO is going to come at the end of your name, is going to convey a lot of that authority. And that's a blessing for us to have. But talking about it in a manner that's not automatically going to shut down the individual, or just educating a vet. You don't need to be an expert marksman to talk about firearms, but you do need to kind of know the point of a trigger lock or gun safe. Are they invalid? Of course not. Things like that. So we've got a lot of experience doing that. We're eager to kind of spread our knowledge. We've got University of New England College of Medicine, who's trialing our seminar as well. UVM up in Vermont is a quantifiable subject. So we're eager to collect more data on this and show that not only is this something that should be involved in curriculum, but huge difference on a national level is not a realistic expectation, but to be able to integrate in your community and to be able to talk to people one-on-one, even if you're just saving a handful of lives each month, each year, or just over the course of your career, those are people who would otherwise not be here. And that's a huge, huge difference.
That's incredible that y'all have done this. How has the administration responded to your seminar? Did they welcome it with open arms, or did y'all just kind of do it on your own?
Yeah, I think I can take this one. Admin, yeah, it's been really actually pretty good at working with our admin. I think our DICE office has undergone a lot of change as well. They were mostly involved in our recent seminar with Hear Me. I think the initial one was more so Charlie and I just really figuring it out and making it happen. Although we did get funding for like food and stuff like that. So I think institution buy-in's been pretty. But we also have very interesting political climate as well. So I think that it's just unique up here, and it's something where like we should be talking about firearms more, and we should be like, curriculum in an appropriate manner, and there's always people that are kind of contrasting that. I mean, my standpoint, as I've kind of alluded to, is very much like patient-centered. How do we make sure it's patient-centered and really avoid bias and some of these harmful, like, well, you own a firearm, so you're de facto in this political group. I just think even talking about that behind closed doors in a healthcare setting is bad for patient care. So that was like my own original motivation. So that's really like, I think we've kind of taken that approach when we explain this to our institution. They've been mostly on board with that. I think like I have my own independent research regarding firearms and like physician bias. That's been a little harder to get buy-in for. But I think the climate up here is it's been pretty good, pretty receiving for it. And moving forward, I think we want to figure out how we can kind of move this into a curriculum component. After individually getting into the SAFE modules and really getting like comparing and contrasting like what we've done and what's available in the modules, and then finding a middle ground for our new members now that we've actively been recruiting and are expanding our group. So moving forward with SAFE modules for our individual group. And I talked a bit earlier as well in the chat about we're working on figuring out how we can do that for medical students. If you wanted to go to that, I think it's not necessary, but I think it's pretty impactful if you can Like, I mean, if I can fire a firearm, I think it at least gives me a better perspective on like how I can talk about firearm safety. So we're working on that stuff going forward.
And
That's
then,
a
okay, go ahead, Jasmine.
Oh, I was just going to say that's a really great point that you bring up, Ken, because there has been research are more receptive to counseling from physicians who have experience with firearms. So whether it's like you've been a personal owner or you've just received training in that, I think gives us a lot more.
That's one of the key, that was one of our founding principles. How do you talk about something with authority? And that comes with knowledge of the firearm. You know, if you sit there and you try and talk to your gun owner about an assault rifle, it'll probably just tune you out, because while that is you know, the big thing is, you know, the takeaways here are there is probably going to be somebody in your system that's going to support this, whether they be a trauma surgeon, an emergency medical physician, psychiatrist, or pediatrician. Those are the big areas. An ex-cop or an ex-firefighter EMT, someone who's done a lot of work in primary care, someone who's got a lot of experience will probably have the consequence, or probably have experienced the consequence of injury or death from firearms. So support is probably out there in nearly every institution, and we really haven't experienced that much political pushback. If anything, it's been overwhelming support.
I think was really interesting is we did a focus group with pediatricians about talking to patients about firearms and what their barriers were. And y'all brought up one of the big ones was that some of them had stopped asking because they felt like there wasn't like an actionable thing to do if they yeah. You know, we Dr. Hurt locks at your school.
For this about 5 to 10 years ago. And in the last couple of years, they've been able to secure grants to have a steady supply of locks at the main campus and at most of their satellite branches as well, including most of their pediatric offices that are attached to the hospital. It is truly revolutionary. I've used it on my OBGYN rotations where I'll be in the labor and delivery and I'll talk to the father and they say, yeah, we've got guns. We don't have time to go get the lock. I can go right down, you know, campus, pick it up from the pediatrician's office and drop it off. And now that guy has 3 trigger locks and he's got a 4-year-old running around the house. For the offices here on campus, there are quite a few grants out there that support this kind of stuff. The legwork is just writing the grants and justifying it. But we get ours from a national grant, I believe. I can't remember what it is off the top of our head. But it is truly an amazing resource to have something concrete that you can give somebody. And willing to build that, they're willing to build that trust with you afterwards.
Yeah.
Right. Something that I feel like we've kind of alluded to through a lot of our discussion has to do with grants and getting funding, right? And so that's also a huge component to what SAFE is physician advocacy, because we're not going to get people to like, I'm just so excited for our generation of physicians. I think we're going to be such great physician advocates, get all the monies that we need to make these grants happen and to get free locks in our clinics. So that's awesome that you guys have that at your school already.
Yeah. I've certainly done my share of talking tonight. Does anyone else out there have questions for these folks at Dartmouth? Any thoughts, comments? It's more than fine if not, but really the work that y'all have done is tremendous. Like that is very like it's above and beyond a lot of chapters. A lot of chapters are doing similar things or different things, but I think y'all are like a shining example of what a safe group can do. And you know, it sounds like you didn't even need us at the beginning, but I think we're very lucky to have.
If we had you guys at the beginning, we'd be light years ahead of where we are now. You know, the key thing is we have kind of a three-pronged approach, educating med students and residents to talk to your patients. We're also integrating with the health equity elective here for those who may be interested in advocacy. I know we're a 501(c)(3), so we don't take necessarily a stance, but for those who do want to take a stance, they can utilize us to get engaged in, you know, lobbying and giving that we're engaging with the health elective policy here. And then, of course, exposure. We are, like Ken kind of mentioned, we do have a small group. Kind of a liquid-filled pumpkin like your abdomen, or a hollow pumpkin like a thoracic chest and things like that. So it's a very educational opportunity, a very good educational opportunity for a lot of our students.
Sounds like a bad day to be a pumpkin. But well, thank y'all. Thank Ken and Charlie. Thank you so much for sharing. Also, thank you to those at Dartmouth and Emory and everyone else who shared this event tonight. It means so much that y'all stuck around later. We appreciate everybody being involved with SAFE, for visiting our website, StandSAFE.org, joining our email list, following us on Twitter and threads at stand.safe. This recording will be available later. But again, yeah, thank you all so much. We so appreciate it, and it means a lot to us. This is one of our few events where we get to really feel how big SAFE is and how many lives it touches. So thank y'all.